Okay, I'll go ahead and get started. I want to make sure that we're mindful of everyone's time. Today is Tuesday, the 22nd of September, and I would like to thank those of you that were able to join us today for the session in our speaker series for Project PaTHwAY. As I mentioned on a couple of our other calls that we've had this month, the intention of this session and the 3 additional sessions that we planned is to kind of give a positive wrap up to this 5-year project that is coming to a close on the 29th of this month. And we worked really hard to recruit individuals that could share useful and insightful information to you all as we close out this project in hopes of helping you formulate how you want to implement the project or continue the project in your own way, because the project will not include funding from this actual funding cycle, but also to kind of help you broaden the way that you look at addressing HIV, viral hepatitis, and substance abuse prevention in your own communities. And I just want to thank all of the presenters for taking time to prepare and present to our group. We do have a small group for this project. There's about 6 sites in California. And it does help us to connect those sites and the staff people working on these projects with people that are very knowledgeable and connected to the different facets of the project and the different topics that we're working to address. So with that, I'd like to introduce Elton Naswood. He's a consultant and he's been working for many years in different areas. A lot of his time has been spent on HIV prevention, and he has a lot of Native and non-Native connections across the country. I'll go ahead and let him introduce himself, and we'll just go from there. Thank you, Elton.
Thank you, and thank you for that welcome. I'm very happy to be here this afternoon to be able to present on information that hopefully will be helpful to you in terms of establishing effective collaborations and hopefully sustainability for your programs as you continue the work within your own communities. I'm going to go ahead and formally introduce myself. Yat Eya Elton Naswood and Shia Tohanin Shnitabahan Bashashin Nakadene Edishay Tetnizani Edishnala Deya Dene. What I said translated in English is, hello, my name is Elton Naswood. I am of the Near to the Water clan, born for the Edgewater clan. My maternal grandfather's clans of the Mexican people and my paternal grandfather's clans of the Tango people. This is how I identify as Navajo. I was born and raised on the Navajo reservation and have lived away now for almost my adult life. Left continuing doing work within the as a part of my journey, I left the reservation to get an education and then also, for the work that I do within the communities that I serve. And I got into public health, I would say about maybe over 12, 13 years ago, first working for AIDS Project Los Angeles and developing and founding their HIV program for urban American Indians in the Los Angeles area. And continued the work and moved to Denver, Colorado to work for the National Native American AIDS Prevention Center. And then most recently went to the East Coast and worked in the Washington, D.C. area, working for the Office of Minority Health Resource Center, and specifically with the American Indian and Alaska Native portfolio. And I've just transitioned back now and live back in the Denver, Colorado area. So it's really good to be near the mountains and near nature and not being so far away. So I'm really happy to be here to give some information that I hope is useful in understanding how to be effective in collaborations, but then also to give information about some regional and national agencies that you can collaborate with, not only for program purposes, but also hopefully for funding and resources as well, because these agencies do provide those, particularly our federal and national agencies. So hopefully this information will be useful to you. So I will go ahead and get started. I see that I can share my screen. I will start now. So welcome again. This presentation is titled Fruitful Ways Tribes, Tribal Health Programs, and Native-Based Agencies Can Partner with National and Regional HIV Entities. I currently now serve as well as the co-coordinator for the National Native HIV Network, but also continue to do consulting as well. So within this presentation, I'll talk about a majority of these agencies a little bit and kind of give some background on how they were established, but also give you some information about the services that they provide as well. There are many Native public health and HIV agencies that include the Indian Health Services, the Tribal Epidemiology Centers, area Indian Health Boards, like the California Rural Indian Health Board that you all are funded by. Also the National Indian Health Board, the National Council of Urban Indian Health, community planning groups as they are termed, which are either state, county, or city. Also talk about the National Native HIV Network. And then also I included the International Indigenous Working Group on HIV and AIDS as well, which is more internationally based, but the United States is represented within that larger umbrella. And then just some other national Native health agencies that you may be able to utilize in the work that you're doing. So just some tips to offer. And these two slides in terms of tips that are being provided are kind of just what I have heard as well as utilized in the work that I did working with HIV programming. So one of the most important things is to build trust and establish rapport with tribal leaders, elders, who are actually gatekeepers for the health issues in their communities, which is really critical. And for some of you who work in the field, you obviously know who these individuals are in your community, how respected they are, but they are really important to get to know when you're outside of your own tribal community. And it's really important to build that trust as well. Also know the history of the Native communities and experiences with the United States and state governments is also important. Not only for the tribe that you serve, or the tribes that you may be affiliated with, it's really important to know what the history is and kind of, the experiences and the cultural understandings that they may have had while being within a certain area as well. And then also recognize the distinctive and similarity of cultural needs from different tribes. Now I know you all are under the umbrella of the California Rural Indian Health Board, which serves a variety of tribes. When you're doing collaborations, it's also good to know about neighboring tribes, and distinguish what similar cultural activities or cultural values you may have, which also can help with that collaboration. But also know that not one size fits all for all our tribal nations as well. So something that you may see that may be culturally appropriate or culturally distinctive for the tribe that you serve may be very different from a neighboring tribe. So it's just really important to recognize that. And then also, most importantly, designate seats from rural and urban communities for the planning groups and make planning more respectful. I will go a little bit into that more in terms of community planning groups, as I mentioned, but even within your own local agencies, if you do have groups that you collaborate with, just make sure that they're representatives of the populations, that you're serving, whether it's rural and or urban as well. It's also important to convene meetings with agencies such as the Indian Health Services and other health programs and tribal officials on how to work more closely together. This may be annual or this may be a quarterly, but it's really important to make sure that you have those gatherings in order to discuss anything that may hinder your programming and or maybe even bringing up some issues that may help your program as well. Advocate for the way agencies are funded. Now this can go under what I discussed as sustainability, but we all know that resources are limited, and the existing resources are not holistic, but rather more categorical. What I mean about that is that, when we're doing work in our own Native communities, most times we come from a holistic approach. It's not, and particularly in the health field, it's not so necessarily the physical aspects that we're trying to help our clients with, but other aspects that are more holistic in terms of like mental health, emotional health, as well as spiritual health. And then when we're going for funding or we're looking for resources, typically it's very categorical. It's very, we're just going to focus on testing, or we're just going to focus on treatment. We need to kind of think more outside that box and be more well-rounded and holistic, so we're making sure that we're providing those services that are important to our Native community. So, when you're in these meetings or you are working with some agencies that may provide funding, be a strong advocate, because if we're not seated at the table, our voices aren't heard and priorities aren't taken into considerations as well. And then the last point I kind of want to talk about is strengthen the infrastructure in your local and tribal agencies through capacity building that is culturally appropriate and encompasses the spiritual framework. What I mean by that is, and most of you are probably going through this right now in terms of either closing out your program or looking at ways to continue to, provide that specific program to your community, but look at different ways on how you can strengthen, your programming, what needs may be there and are needed, whether it's, data collection, where to get the best data so you could apply for funding, or if it's just the needs assessment that, you may need to broaden your program to not just be about HIV, but more generally that can include STDs or healthy lifestyles or what have you. It's just important to be able to do that and build that capacity, but also staying true to, the cultures of the communities that you serve as well. So those are just some tips I wanted to share briefly, and hopefully it can transcend into those relationships that you'll be building with some agencies that I'll provide some information to as well. So this is another important slide I also wanted to share, and this may be for some agencies that may work with non-Native agencies, or do collaborations. But in tribal public health, there are processes that are important for people to know and understand. Obviously, as I mentioned, you got to build trust, and also make sure that that collaboration includes mutual beneficial partnerships. Sometimes, we've had a history as Native people of not trusting particularly government agencies, around health issues. So, when someone comes and wants to do a health project within your community, they got to be very invested on what is going to be done, but also to, respect and build the trust of the community that they may be researching. So that's just one example. Also, it should be important that there are legal requirements for tribal consultation. So when I use the word tribal consultation, that's more of a federal term so to speak, but it's also can be used with individuals who are coming in to your communities and should be knowledgeable of tribal laws and requirements, whether they're doing research or even providing programs for your communities. Because as tribal communities, we have our own tribal laws that enable us to be sovereign. Back to research per se, there are tribal IRBs, which are institutional review boards, as well as the need for tribal resolutions if any programs are going to be done, and or if you're proposing to do, to continue the project in terms of, providing proposals, you may need to get these certain documents approved by the tribe in a way. And those are just safeguards and to let the tribes know of your intent on the programming that you're doing. Or the collaborations you may be establishing with other agencies as well. Seek permission as well as collaboration with appropriate area Indian health boards, tribal epidemiology centers, advisory or community committees that may exist in the communities, as well as tribal state liaisons or tribal state offices that may exist, and see if there's any regards and how that may be, if there's anything else needed in that process for approval, etc. So I just wanted to bring that slide up just to kind of give you more of an expansive understanding of, some of the legal stuff, but also just to ensure that when collaborations are being done, that, you are knowledgeable about what may be required or not. So I'm going to start to begin to talk about some national agencies, and most of us are aware of the Indian Health Services, which is a federal agency under the Department of Health and Human Services of the federal government. Oh, this is better. Of the federal government, and their mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. And this slide just kind of shows some of the burdens, that exist for Indian Health Services, but then also some of the successes that they have been able to do in providing HIV services for our tribal communities. The Indian Health Services serves approximately 2,200 patients living with HIV nationwide. The HIV drugs and medications are now part of the National Core Formulary, which was a really good step that IHS took, which also can include the use of the pre-exposure prophylaxis medication as well. So that was something of a success, particularly from a federal agency for our communities. There is a high dependence on our third-party payer system. So some of you who do work in clinics kind of understand that. Most of the sites refer HIV care to outside non-IHS facilities. Few patients, and then they also have few patients at most of the clinics as well. There is obviously also a lack of clinical experience in treating HIV that exists in some of the health programs and clinics that IHS has. Some of the challenges as well as there's a lack of visibility on patients who leave IHS for care. There's no centralized IHS lab data system for all of Indian country, and screening is being monitored nationally as a core metrics. So those are some of the challenges, and you all may have experienced that within your own programs and your own clinics when you are referring patients for HIV care as well as treatment. A majority of the clinics are primary care clinics. A majority of them are in rural areas, and IHS is divided into 12 different area offices as well. That you may be familiar with more specifically. There are main treatment sites in the United States for HIV, one of them being on the Navajo Nation, as well as Phoenix, Arizona, which has an HIV Center for Excellence clinic, as well as the Cherokee Nation in Oklahoma, who has their own clinic as well. And then for our relatives in Alaska, they have a clinic in Anchorage, Alaska there. So some of the good things that IHS has done, I should say good things, but some of the more prominent services that IHS has done within the last couple of years is, again, I mentioned being able to get the medication on the federal formulary, but also they do have a national HIV and hepatitis C program. They've combined and added Hep C to the programming, which is really great. And they serve as a national comprehensive resource within IHS and aims to include all service delivery systems, both internal and external, including IHS, tribal and urban facilities. The program goals include input from community members, organizations, people living with HIV and AIDS, providers, federal agencies, healthcare workers, and tribal and urban representation. So this program actually does provide some funding for programming or access to be able to do some work within the HIV field from federal resources, but it's also manned by one individual, which can be limiting to a certain respect. But I'm not sure if people know Mr. Rick Haverkate. He has been in that position for several years now and has really made it a point to be able to meet with Native agency staff, providers, as well as people living with HIV and AIDS, and has really done a tremendous job in raising the issue of HIV, as well as hepatitis C within the federal agency of IHS. They've also formed and is now more actively being done in meeting is a Two-Spirit LGBTQ work group, which was established in 2010 to unite to create LGBTQ Two-Spirit work group in order to advance the equality, health status, and well-being of all LGBT Two-Spirit American Indians, Alaska Native individuals, their families, and their communities. Interestingly enough, it was created in 2010, but has been actively meeting and providing services and projects primarily under the leadership of Mr. Haverkate, but they've done some amazing work in providing trainings for clinicians, for providers around issues relevant and pertinent to Native individuals who identify as Two-Spirit, lesbian, gay, bisexual, transgender, or queer. And I've really seen a lot of work being done, trainings online, as well as some programming, which the image on the upper side of the slide is to be able to text LGBTQ2S to 97779 to learn more about Two-Spirit and LGBT health. So if you're within your program or you're needing information because you may have a client who identifies as Two-Spirit or LGBTQ, you can text that and get some good responses from individuals at the Northwest Portland Area Indian Health Board, which is one of the funded agencies to provide this service. The LGBT Two-Spirit population has unique healthcare needs and is also at greater risk for health threats and often experiences low quality healthcare due to a variety of factors, including discrimination. All people receive health services that are formulated to address their particular circumstances and meet their individual needs. So, you know, by having that work group, and I served on that work group when I was in Washington, D.C., you had a number of clinicians, primarily from rural areas, on these work group calls to be able to ask questions on how to be able to provide better services, for instance, to a transgender individual who comes in, and making sure that they ask the appropriate questions. You know, about their healthcare. So, you know, it gave a space where people felt comfortable. And I think from what happened with that discussion, they've actually now have implemented some ECHO programs, which is more of a virtual platform where clinicians can call in and get advice on how to work with clients from this specific population. So, you know, it's a really big step forward. I'm really proud of what they've done at Indian Health Services, as well as the advocacy and inclusion of the specific populations, because we know that this specific population is at high risk for HIV within our communities and in general as well. So this is just a map. As I mentioned, the Indian Health Services is broken up into 10 regions, I'm sorry, 10 regions, and this map just kind of gives you an indication about what states are in certain regions. So for you all in California, you're your own region because probably because of the amount of tribes that are in California and the vastness of the state. So California does have their own IHS region as well as the state of Alaska, which is bigger than most states here in the US. And the East Coast is primarily just all under the Nashville area region there. Because, you know, there's not a number of tribes as per se, California. So this is also a map of the tribal epidemiology centers, which there are 12, as well as the area health boards. So the different color of the maps give you an indication of what states are under the different health boards that exist, and then also where the tribal epidemiology centers are located as well. Moving on, the tribal epidemiology centers is also a great agency to collaborate with, and particularly within your area of California, not only to help with the data that you have within your own agencies or your communities, but also to help you in gathering data more specifically for things like report writing, for proposal writing. It's really important to be able to make that collaborations with the techs, as we call them. But they have been established via the Indian Healthcare Improvement Act. It started out in 1996 with 4 and has expanded now to include 12 tribal epicenters. They function independently, but also as a part of a national group. Their funding specifically comes from Indian Health Services through a cooperative agreement with the IHS Division of Epidemiology and Disease Prevention. In 2010, which is just 10 years ago, under the Affordable Care Act, they became permanently reauthorized via the Indian Health Care Improvement Act. And what that means is that the budget is set forth, and so they will always or continuously be funded unless there's some other legislation that doesn't allow it, which is a good thing. The tribal epicenters are given public health authority status, and then the Health and Human Services directed to give the techs access to HHS data systems and project health information. Which is important because they have access to the federal data systems in case you need to get those numbers nationally. The CDC and prevention must provide the techs with technical assistance, meaning if they need more capacity building or they need more training, then the CDC will provide that for them. And each IHS area must have tech access. And again, like the map showed, there is a specific tech for the California region. The techs serve 7 core functions, which is obviously to collect data, to evaluate data and programs, and to identify health priorities with IHS, tribal or urban healthcare centers, make recommendation for the health services needs, and make recommendations for improving healthcare delivery systems. And then finally, to provide epidemiology technical assistance to IHS, tribal or urban healthcare centers as well. This is another map, more visual, that shows you where the epidemiology centers are located. I believe in California, that epicenter is with CRIP, if I'm not mistaken. And so you also have the Urban Indian Health Center in Seattle, the Intertribal Council of Arizona in that region there, the Albuquerque area, Southwest, and then the Navajo Nation has their own epicenter, the Rocky Mountains, Northern Plains, Great Lakes, United South and Eastern Tribes in Memphis, Tennessee, Nashville, Tennessee, and then the Oklahoma area. So those are the 12 epicenters. So urban Indian health centers, which you may be familiar with, provide services to our urban Indian population. And I think with the recent census, I believe maybe up to 70% or maybe even more of our Native population live in urban cities, urban areas. And so it was really important to ensure that we all are able to provide the healthcare within their cities for our American Indian Alaska Native community. And so the urban healthcare centers were established in 1976 by Congress through the Indian Healthcare Improvement Act. It considers health reform legislation to improve the health and well-being of our Native communities, as well as within the urban areas, which is under Title V. There are 41 programs engaged in a variety of activities ranging from provision of outreach and referral services to the delivery of comprehensive ambulatory health care. 15 of the programs are designated as federally qualified health centers, FQHCs, and provide services to Indians and non-Indians alike. So throughout the country, we do have 41 programs. Of those 41, the 15 are actually FQHCs that provide direct services, healthcare services to our urban Indian population. HIV and AIDS and sexually transmitted disease information is provided at conferences, seminars, workshops, and community meetings at all of the IHS Title V funded off-reservation Indian health programs. These education and prevention services include culturally sensitive information provided to a variety of audience through the use of posters, pamphlets, and presentations and community education. Additional HIV/AIDS services include HIV testing, pre and post-test counseling, family support groups, and referral for additional treatment for HIV and AIDS. So that primarily means that of the 41 programs, other than the 15 federally qualified health centers, a majority of the urban healthcare centers are more informational, where they give out information about primarily HIV or HIV prevention. And some of their services, like HIV testing or treatment, are referred out to more health services that are more clinically based. So that's kind of the difference with the urban Indian health centers, whereas with an IHS clinic per se in a rural community, you have access to the clinics within that, within that jurisdiction. So HIV prevention programs can be, can refer people directly to the clinics at an IHS health center. For urban Indian health centers, it's primarily a referral base if they aren't a federally qualified health center to provide those services. And I've had experience with that in early, when I was living in Los Angeles and we had an HIV prevention program for American Indians, Alaska Natives, primarily gay, bisexual, and transgender individuals. We would able to do prevention services, do testing, but then when it needed more clinically based treatment, we would have to refer them out to some of those clinics within the Los Angeles area, which might be county health, USC County Health. But also we worked in collaboration with the United American Indian involvement. So that was something that I experienced with these urban Indian health clinics, health centers, I should say. So this, again, this is a map of where these urban Indian health centers are located. There are a number in California, as you can see, to 8, I believe 8 health centers there. And then you have just a few on the East Coast. In Baltimore, which I have visited, Native American Lifelines, and then also they just expanded into the Boston area. And from where I'm presenting in Denver, we do have an urban health center, which is the Denver Indian Health and Family Services. So it's important to know where these health centers are, and particularly for our folks who live in these areas, it's important to be able to make those referrals. And we know our population, they're very, we're very transient in a way that we go to an urban area for whatever it is, whether it's school, or whether it's for work, but then oftentimes we go back to the reservations or tribal communities. So it's really important that we know where these services are, particularly for those individuals who may be HIV positive, so they can access some of their healthcare and treatments from these centers, or be able to make referrals from those centers. I remember when I was in Los Angeles, I had clients that would go to Phoenix for whatever reason. So I made that collaboration with the Phoenix Indian Medical Center and let them know that I had clients that may be there, for some time, and that they need to pick up their medication. So it really took that extra step to be able to make that collaborations. And it worked out great for some of the clients that I was being able to serve as well. So it's important to know of these centers. As I mentioned, there is what are termed community planning groups in state, county, and city jurisdictions. They may be termed something totally different, but the initial concept of community planning groups were that communities were represented of the populations that they serve, and then they set intervention priorities and collaborations with funded government entities. And what that primarily means is that, for instance, the CDC used to have specific funding to have jurisdictions develop community planning groups. Back in the late 2000s, there was actually direct funding for that. And they worked pretty well. They were able to galvanize agencies and community leaders and advocates, as well as clients, to set these priorities. And it was really important that we were represented as a population as well, meaning that American Indians, Alaska Natives were a part of these groups. But hence then the funding allocations have changed, so community planning groups are not directly funded from the CDC, but the concepts still are involved in some of the funding that is available. And some jurisdictions have continued this concept because it worked very well for them, and I'll highlight a couple that are still active in that way. And that recently changed a couple of years ago, because they used to have a prevention planning groups, and then they had a Ryan White funded treatment planning groups. And within the recent years, they kind of merged together, which has caused some conflicts in some jurisdictions that I've seen, but majority of them have been able to work together. It's the same health issue, but I think it was just, the resources that were available. And I seen that particularly here in Colorado. When I lived here, I was a part of that group. And so it was a big transition. So HIV planning is a critical process by which health departments work in partnerships with community and key stakeholders to enhance access to HIV prevention, care, and treatment services for those for the high-risk populations. The challenge has been the inclusion of American Indian, Alaska Native populations to be represented. Currently, certain jurisdictions have active community planning groups. And then on this slide, I highlight 2 state and city CPGs, more so on the East Coast, that being the New York State Interagency Task Force on HIV and AIDS, which is a state community planning group. I know the American Indian Community House in New York City has representatives on that state interagency. And then also a colleague of mine serves as the American Indian Alaska Native representative on the Baltimore City HIV Planning Group and Commission. And it's really great to be able to see that they're being inclusive, but it's taken some advocacy to ensure that they are included in those specific planning groups, and then have access to some of the resources that may be available through those planning groups. These 2 planning groups that I'm highlighting here, one is more local for you all in California, But then the other is in the New Mexico area, and I'm playing around with this screen so I can read my slides. I apologize. So in New Mexico, the state of New Mexico, they term their group as the New Mexico's HIV Community Planning and Action Group. In 2005, the CPAG expanded its mission to conduct planning for all activities related to HIV, including HIV medical treatment, support services, and other care for persons living with HIV. So when I mentioned before, they kind of consolidated, the two planning groups, but New Mexico successfully was able to do that. The CPAG worked during 2005 and 2015 and 2016 to create the state's first integrated plan for HIV prevention and care. The 5-year plan describes work to improve HIV outcomes during 2017 up to 2021. So they're actively meeting and utilizing that plan on a state level. I've actually had the privilege of sitting in on one of their meetings, which was amazing experience, because they had about maybe 30 to 40 members from throughout the state at these monthly meetings, and people were able to voice their concerns. And a majority of that, of the participants at that meeting were from a group called the Southwest Indigenous Initiative, SWE, which was actually formerly one of the regions that was termed Region 7, that was specifically for American Indian tribes and nations within the state of New Mexico. So, the state really advanced that to be inclusive of the American Indian, Alaska Native, American Indian community and representation, but the community also advocated for that. And they did create the Southwest Indigenous Initiative now. And a majority of the people are represented by the tribes in New Mexico and the Pueblos as well. So when I mentioned earlier as part of the tips, it's important that we make sure and ensure that we have a seat on these planning groups as well. The other, which is more locally based for you all in California, is the California Planning Group. The CPG is a statewide HIV planning body that enables key stakeholders, communities, and providers to engage in active and ongoing dialogue with the Office of AIDS to reach the goals of the National HIV/AIDS Strategy and statewide integrated plan. So similarly, they have a plan, as does New Mexico, that correlates with the national strategy that they utilize, and the CPG is committed to work openly in a group to make decisions and is guided by principles of equity, fairness, and respectful engagement. I know this particular group has had challenges in getting American Indian, Alaska Native representation on the planning group. And currently they have an Indigenous member, Carolyn Ku'ili'i, who is Native Hawaiian and Apache and lives in the Bay Area, that is a part of the California Planning Group, but I believe she is going to be transitioning off, or she has very recently, but they are going to be looking for membership for that state California Planning Group, which I think is critically important for American Indian and Alaska Native communities to be seated at the table and continue that representation as Auntie Carolyn has done as well. So I just wanted to give an example of a community planning group that is specific to your communities there. So now we have the National Native HIV Network. So I'm gonna go ahead and play a video for you all. Okay, I gotta stop share here, I guess. And then let me go here. Oh, how do I do this? Sorry. Okay, and then let's see. Okay.
The National Native Leadership Network aims to bring together Native people from across the country to foster leadership and skills building, provide voice, and strengthen collaborations and partnerships to address HIV in our communities. The network started in 2016 and has held 5 gatherings. The first event took place in September 2016 during a roundtable at the United States Conference on AIDS in Fort Lauderdale, Florida. This first session focused on the question, what steps could we take to ensure successful implementation of a national Native network? The steps that participants brainstormed highlighted areas that focused on the history, the community, and sustainability. The next event took place in April at the 2017 Circle of Harmony HIV/AIDS Wellness Conference in Albuquerque, New Mexico. This session continued to develop on these areas through a focused conversation with attendees. That same year, in September, the next network activity was held at the United States Conference on AIDS, this time in Washington, D.C. This session was focused on action planning, where attendees envisioned what success for the network would look like. We discussed strengths, benefits, weaknesses, and dangers, as well as group commitments. Key actions were collected by answering the question, what are specific activities we need to take to move forward our intent to create the National Native Leadership Network? Next, a 2-day session was held in July 2018 in Albuquerque, New Mexico, that brought together 31 participants from tribes and agencies in Arizona, California, Maryland, Minnesota, New Mexico, Nevada, and Oregon. During this skills building and strategic planning session, participants answered what are the trends, paradigms, and approaches in the field of leadership. Then, a consensus workshop was held to discuss what are effective ways we can support leadership development within our group. Finally, the network held a session in September 2018, again at the United States Conference on AIDS in Orlando, Florida, that invited participants to discuss barriers to developing the network. The network was developed as a collaboration between the Albuquerque Area Indian Health Board, the Office of Minority Health Resource Center, JSI Research and Training Institute, and Indian Health Services. But as we continue to strengthen our network, we welcome other organizations, agencies, and community members to get involved. We look forward to your participation and support.
Sorry about that. I think we were here. Okay, and hopefully you could hear that. I don't know if the volume was loud enough. I apologize. I was trying to turn it up on my side, but hopefully it gave you a visual if you couldn't hear. But basically, I'll reiterate what the network is and what we do. So the National Native HIV Network, which it's now formally called, we started calling, as per the video mentioned, the National Native Leadership Network, then the National Native HIV/AIDS Leadership Network. We finally settled on the National Native HIV Network. And in HN, and as the video mentioned, we were created in 2016, 2017 as a community-led response to increase and organize the national Native voice and presence in the HIV movement. There has been limited national presence, national organizations or agencies that a number of us felt like, we needed that national voice when it became critical when we would respond to like the national HIV/AIDS strategy, national funding requirements. So hence this network was created. It took several years because we wanted to be very intentional, but community grassroots led. but obviously we do get support from the HHS Office of the Secretary of Minority HIV/AIDS Fund and Indian Health Services, as well as through the Albuquerque Area Indian Health Board, who actually is the coordinating agencies for the network. We have key stakeholders from across the United States that form the NNHN. That is a picture on this slide of individuals that were part of the network that we did our regional meeting in Anchorage, Alaska this past February, at the end of February, which is right before the national shutdown due to the COVID-19. So that's just a beautiful picture. I believe it was like 10 degrees or something. So we were freezing, but that is just some individuals who represent different areas throughout the United States. The network provides input and guidance to assist Indian Health Services and other agencies in efforts to reach high-risk American Indian Alaska Native populations with HIV testing, prevention, and treatment. We also build capacity, group capacity, and provides assistance to support extensive community engagement strategies, dissemination of information at regional and national levels, and support professional and leadership development to sustain these efforts. Currently, we have a couple of seats available for the California region. So we will be doing a call out and announce a call for individuals who want to be a part of the network, and we'll be targeting those regions that either we need more participation or we need representation, and one of them being California. I believe during our last meeting, it was discussed California would be its own region, but then we would have representatives from Northern California as well as Southern California. And then Central California, will probably where a lot of you are at, you kind of got to pick a side. No, I'm just joking. But so we will have seats available, and we'll be doing that announcement very soon, if not by the time for the next United States Conference on HIV and AIDS later next month. So if you are interested, please do let me know, or we will send that information out for anybody who might be interested. It's very grassroots. We get input from everyone. And one of the tasks that the network has taken over is to organize the National Native HIV/AIDS Awareness Day, which happens every year on March 20th. And so the image to the right was the photo or the poster that we developed collaboratively and came up with the theme for this past year, which was ending the HIV epidemic in Native communities, resiliency plus action. So we distributed these images and posters via email as well as through social media to encourage individuals to get tested on this special day. And the NHAD, as it's called, is a mobilization effort that helps to encourage our Native people, including American Indians, Alaska Natives, and Native Hawaiians across the US and territory areas to get educated and get tested and get involved in prevention and get treated for HIV and AIDS. It was founded in 2007, and it annually happens on March 20th, which is actually the first day of spring. So that conversation was had through, with community and feeling that it's a rebirth, the first day of spring, hence the date March 20th was selected. Another thing interesting about collaborations, and particularly around National Native HIV Awareness Day, is that it also could be utilized in your own communities as a policy discussion, getting proclamations from your tribal government, but it really begins to raise awareness about HIV and AIDS in our communities. So during events during this time, during posters, I've seen different agencies ask their community leaders, their city councils to make a resolution. I know when I worked in Los Angeles, we had the city of Los Angeles and the city council do a proclamation of identifying National Native HIV Awareness Day for March 20th. So it can be used as a example to open those doors for discussions and collaborations, but also utilize as a way of developing policies as well. Another task the network is doing is now, because of COVID-19 pandemic, we are doing webinar series monthly. And so we started this in June. We started this in June, I'm sorry, of this year. And as a part of the network, we discussed what topics we could have. People identified professionals with a background in these topics. And so we created these monthly webinars, which typically happens the last Thursday of every month. And so in June, we had HIV self-testing. We also provided our membership in our region self-testing kits that we purchased, and they were able to distribute. We had presenters talk about how that is being done. We also talked about continuing PrEP services during the pandemic. So we had presentations from Dr. Jorge Mara of the Cherokee Nation, who talked about how they're doing PrEP services during the time of COVID, whether it's through virtual Zoom meetings and dropping off of medications for people that are safe. So we've had that presentation as well. And last month, we recently had a very fruitful discussion. We had to extend the time for the webinar, but it was on harm reduction strategies during COVID-19. So we had a number of our colleagues from Alaska as well as New Mexico who talked about how they're still providing syringe exchange services, as well as harm reduction approach during COVID-19. So we're really excited about that. And the network has agreed to continue these monthly webinars throughout the year. So we will have other topics that we could send out information on. I believe our next webinar will be on October 1st on the same issue of collaboration and sustainability. Also, topics will include HIV in elders, transgender health issues. So we're hoping to organize those events throughout the rest of the year. Other activities that we're going to be doing is to develop a national HIV services directory. We're going to be launching our social media activities with a website on World AIDS Day. We are actively involved on Facebook, so look us up on Facebook. And then also having conference participation. I know this week there is that National Native Harm Reduction Summit that people are involved in, as well as I mentioned, the United States Conference on HIV and AIDS next month, and then also planning in collaboration with the Albuquerque Area Indian Health Board, the Circle of Harmony Conference next year. We'll also be doing a World AIDS Day campaign as well, so we'll be developing social marketing materials that we can share with you as well, that you could share with your networks and your collaborative agencies as well. So finally, we talked about state, local, national, and now we're talking international collaboration. So IGWA, which is the International Indigenous Working Group on HIV and AIDS, is an international voice and structure for Indigenous peoples throughout the world to be advocates for our Indigenous communities in different countries. It includes Indigenous leadership, varying levels of government and aid service organization, and cooperatives and other global collection action to lower disproportionate impact of HIV and AIDS experienced by our Indigenous people. It also helps to reduce the spread of HIV and increases the quality of life of strengthening collaborations between international and Indigenous communities while expecting our autonomy and diversity. It also, one of the missions is to increase culturally appropriate prevention, care, treatment, and support of HIV/AIDS through collective advocacy, education, and sharing of wiser practices and socioeconomic evidence. This international Indigenous group produced an international strategic plan for HIV and AIDS among Indigenous peoples and communities from 2018 to 2014. So we just recently updated this plan and included more biomedical interventions to it as well. So I am fortunate to serve on this working group and this international organization as one of the United States leaders is what they term us. But I serve on there as well as Ben Genobi, who is Yankton Sioux and lives in the New York area. And we both serve as representatives from this group. We have around about 12 to 15 individuals from throughout the world that meet quarterly, virtually. It's a very humbling experience because there needs to be interpretation for our relatives who don't speak English per se, but it's a lot, it can be a long meeting, but it's a very informative, and it just is very empowering because you get to work with other Indigenous communities throughout the world. And it's interesting as well to understand and know and be knowledgeable about how other countries, particularly our Indigenous peoples in these countries, have to go through in terms of some of the information that I shared in terms of prevention and care, sustainability. So we work collectively. We do have some work that does go to the UN, United Nations AIDS organization as well. So we ensure that there is inclusivity and that Indigenous issues are on the table. And just this past July, the International AIDS Conference was supposed to be held in the San Francisco Bay Area, but because of COVID, it became virtual. So at every International AIDS Conference since 2008, I believe, they've had the International Indigenous Working Group on HIV and AIDS has held a pre-conference prior to the large international conference that's specifically Indigenous. So this past year we did a monthly Indigenous pre-conference, meaning that we held 3 days throughout the week to do presentations. We did a formal opening and a formal closing, but just so people didn't get zoomed out, we expanded it over the whole month of July, where we had presentations from individuals from throughout the world. And fortunately, our communities and some of our agency leaders were a part of this. So hopefully in the next 2 years, we'll be able to, continue to do this pre-conference as well. And we had some good representation from the California agencies and tribes during that pre-conference. So we really appreciated the participation and representation of California Indians and tribal nations. So just fairly quickly, these are some national Native health agencies that you may be aware of or not aware of. We have the National Indian Health Board, which is located in the Washington, D.C. area, but they were established by the tribes to advocate for united voice of federally recognized American Indian Alaska Native tribes. They seek to continue to strengthen tribal sovereignty and tribal health systems at a federal level. So they do a lot of policy work. They also do a lot of advocacy for health resources and funding and policy in the DC area amongst Congress and some of the federal agencies. They represent the tribal government specifically, both those governments that operate their own healthcare systems through contracting and compacting, but also those that receive funding from Indian Health Services. They continue to present tribal perspectives while monitoring federal legislation, as I mentioned, which opens opportunities to network with other national healthcare agencies to encourage support for Indian healthcare issues. The area health boards serve as member organizations to NIHB. So California Rural Indian Health Board should have a member who represents on the national level with NIHB. And they're the link between the national organization to the tribes The member organization advises on the development of positions of health policy planning and program design. They also hold big, large conferences throughout the year, and I believe they are sponsoring this year's or organizing this year's National Harm Reduction Summit as well. So they are another good health agency to know. And then on the other side of that, there is the National Council on Urban Indian Health, NCUI, which is also a national organization that supports and develops the quality, accessible, and culturally competent healthcare services for our native populations living in urban settings. They were established in 1972 by Congress to fulfill the federal government's health-related trust responsibility for Indians who live off the reservations. And they are managed by an executive director and a board of directors. NCUI is the only national 501c3 membership-based organization devoted to the development of quality, accessible, and culturally sensitive healthcare programs for our urban Indian community. They are also located in the Washington, D.C. area. I know a number of their staff as well as their executive directors. Both of these national agencies do include HIV and AIDS in their advocacy as well as within their own programming. So they are really important organizations to know of. And this is from NCUI's website of the National Urban Indian Health Centers. And then these are national Native agencies other than the ones I presented about, but it's also important to be knowledgeable of the National Congress of American Indians, the it should be the American Public Health Association, which is the large public health organization in the country, but we have the American Indian Alaska Native Hawaiian Caucus, which I'm currently involved in. So we do advocacy at that national level as well. So if you're interested in the caucus and the APHA organization, they are doing their national conference later next month as well. And it'll all be virtual. The American Indian Public Health Resource Center, which is at North Dakota State University, is also a good resource. 7 Generations, the Center for Native American Youth, First Nations Development Institute, and then some federal agencies that correspond with our health agencies are the Bureau of Indian Affairs and then the Bureau of Indian Education as well. And particularly for the youth-oriented programs that you all have been serving, they would be important to know of. And then some of these agencies do also have funding opportunities available as well. And these are just the websites of resources if you want to access them. Indian Health Services, National Indian Health Board, National Council of Urban Indian Health, International Indigenous Working Group on HIV and AIDS, the National Congress of American Indian, and for the National Native HIV Network, as I mentioned, we are on Facebook and we will be getting a website fairly soon and hopefully launched by World AIDS Day. So I believe that is it with this presentation. I want to say a yaha. Thank you for allowing me this time to present this information. Hopefully it was informative and will begin to help you plan for your continued either sustainability or continued programming that you have done with the California Rural Indian Health Board the last 5 years. I commend you for all the work that you do and you will continue to do for the health of our Native people. So yeah.
Elton, can you turn your share screen off and then I'll share my screen?
Okay. Oh.
If you guys could just hold on 1 second, I have a poll and then a wrap up, just a couple minutes.
Okay.
Thank you. Okay, I'm gonna share my screen and I don't know where my poll went, just 1 second. I swear that thing hides sometimes. I'm not sure where it goes. Let's see. If I can't find it, then we'll just skip it, but I'll look one more time. Okay, well, I can send out the poll to you by email, and then you guys can just respond that way. It was just a little wrap up of, how helpful the information is, and if you guys plan on working on HIV, viral hepatitis, or substance abuse topics as we move forward once the project ends. So that's just a little bit of additional information for the CRIB staff so that we know what's going on your end. But in any case, I wanted to also give a special thank you to Elton for the time that you spent preparing this presentation, and then also for sharing all of the information that you put together, resources and tips and tricks and ways for us to stay connected with other organizations and entities that are doing this work as we move forward. Does anybody have any questions? If you have questions, you can feel free to type them in the chat.
Don't be shy.
Let's see. I don't see any questions yet. Okay, so I will send out this recording with the other two. We're working with our media specialist to do that. And there's one more session on Thursday, which is Art as Activism, which will be presented by Cheyenne Garcia. So I will send out a reminder for that session. I hope you all can join us. And if not, I will send out the recordings, and they'll most likely be posted on either their CRIB Facebook page or the website. So we're working on that. And with that, I just wanted to say thank you for taking the time to spend with us today. And thank you for all the work that you've been doing. Take care, Elton. Thank you for joining us.
Thank you. I appreciate it. Yeah.
Bye, guys.